Hi, everyone. Welcome to this episode, this Perry Talk on sexual pain. And we're going to start with some introductions and then get right into your questions. I'm Dr. Laurie Mintz. I am a licensed psychologist and a certified sex therapist, and I'm the author of two books, both aimed at empowering women sexually: A Tired Woman's Guide to Passionate Sex and Becoming Clitorate. And now Dr. Johnson will introduce herself.
Hello, everyone, and welcome. I'm Dr. Suzette Johnson. I'm a board certified obstetrician gynecologist and have been working for almost 3 decades, focusing mostly now in my career on sexual wellness and menopause. I also specialize in advanced gynecologic ultrasound, and I'm really glad to be here today to take on some questions and see if I can give you some advice and help.
And I personally know Dr. Johnson not just as a friend, but as my physician. She's wonderful. And I think what she forgot to tell you is that she's a fellow of ISWISH, which is the International Society for the Study of Women's Sexual Health, which means that she's been recognized as one of the most experienced and premier doctors in the field. So we're so
Thank you,
lucky.
Lori.
You're welcome. We're so lucky to be here together talking to you and answering your questions. And there were questions that were sent in advance. So what we're going to do is that we're going to read the questions and then answer the questions for you. The first question is from the Perry community, from a 47-year-old woman who says, "Why does sex suddenly start hurting in my 40s? I'm horny, but the pain makes me not want to do it. It never hurt before, not even postpartum. I am desperate." Dr. Johnson, would you answer that question for this community member?
I would be delighted to. This is something that is so common, and I hear this in my practice day in and day out. And what is happening is that as we start to get older and start to transition into menopause, our hormone levels are shifting and fluctuating. That hormone that is so important is estrogen. Also, testosterone comes into play, but estrogen is the key hormone here. And what happens is as the estrogen levels fluctuate, it affects the tissue of the vagina. Vagina is so happy to have estrogen. It helps with its elasticity, its lubrication, and the thickness of the vaginal tissue. And as the estrogen declines, that tissue starts to really change in terms of its elasticity. It gets thin and it doesn't lubricate well. And so you can experience burning, and patients describe things like razor blades and penetration hurts. And the thing is this is something that is so treatable, and you can get help by just using simple things. So initially, you can start by moisturizing your vagina. Using a vaginal moisturizer, meaning maintenance. You do this every week, 2 to 3 times a week, and you can see a huge difference. Patients have described this as life-changing for them. Other things you can do is use lubrication when you have sex. It's so important. Even though you may feel arousal and feel real lubricated, you still can experience some things where after sex, you might feel some pain after sex. A lot of my patients say, I feel great, I'm lubricated, but after sex, it kind of burns and it hurts to pee. Well, you can experience micro tears, small abrasions in the vulvar and vaginal tissue that can cause that. And this whole thing that what I'm talking about is called the genital urinary syndrome of menopause. And that's what happens as we start to transition into menopause. But this is treatable and you can experience good sex again.
I just want to add that I mentioned earlier, I'm a licensed psychologist and sex therapist, but I'm also a woman who's gone through menopause. Dr. Johnson was my doctor, and she recommended all those things to me, and sex stopped hurting. So these are really doable things that every woman can do.
And bring this up with your provider. The vaginal estrogens can come in pills, they can come in rings, cream, and even suppositories. So there's many different ways that you can provide estrogen safely and effectively to your vagina.
Yes, I mean, we'll talk more about this later in response to other questions, but I can self disclose under Dr. Johnson's guidance, I use vaginal estrogen twice a week and a moisturizer other 2 times a week and lubricant during penetration. And sex is no longer painful. You don't have, sex does not have to be painful.
And also, I think that we should mention, Laurie, that some women also require a little bit more therapy in the realm of pelvic floor physical therapy, because sometimes as we are experiencing this and we haven't addressed it soon enough, we can start to have changes to our muscles because we have muscle memory, and we can have tightening of our pelvic floor muscles. And you should know that if you in the United States, in all 50 states, you can self-refer to a physical therapist, even pelvic floor physical therapy. There are restrictions in terms of what you can get in each state, because some will give you the referral plus they can complete the therapy, but other states require you some type of prescription from a provider. However, you always can self-refer in all 50 states.
Excellent. Excellent. So good to know. So let's move on to the next question.
Yes. I'm going to ask you, Laurie. This is a question from another one of the Period community members. And their question is, how do I know if this pain is just hormonal or something more serious? My health anxiety is kicking in.
Oh, well, of course you're anxious because we're used to kind of walking around, everything feels good and it's fine. And then suddenly, if something hurts, we're like, oh no, what's wrong with me? So that's quite normal to worry about that. What I want to say is what Dr. Johnson just described, right? The decreased estrogen that starts causing vaginal tissue to dry, starts causing pain. You are in the age group that is happening to you, and sex is now painful. So the most likely scenario is that's what's going on and it's nothing more serious. But the only way to really know that is to see a physician. And I strongly recommend that you see either a sexual medicine physician, which you can find at the website of the International Society for the Study of Women's Sexual Health, or the NAMS. What's it called, Dr. Johnson?
It's now called the Menopause Society. Yeah, so you can go to the menopausesociety.org and you could search in your state and look specifically for a provider in your area. And there are so many doctors, nurse practitioners, family practice doctors that are certified in menopause. So you can find them that way.
So what I want to say is, yeah, you're anxious because something's new, it hurts. It's probably everything we're talking about today. But the only way to really know is to see a physician. Don't avoid it. Don't, push it off. Hang up from this call today, make yourself an appointment, and then you'll know. But I also want to reassure you that the most likely scenario, right, is this is due to the genitourinary syndrome of menopause. And someone in the audience asked a question. Is this only for the US? I'm in Canada. Can people in Canada get pelvic floor physical therapy, vaginal estrogen, hyaluronic acid? Do you know the answer to that question, Dr. Johnson?
I don't, but I think you could probably go and search online to see if you can self-refer. But there's definitely going to be pelvic floor physical therapists in Canada. I have some colleagues in Canada, and certainly I know that they do pelvic floor physical therapy there. So I would just either speak to your provider or just search online.
Oh, and she says she's referring to the ISWISH physician list. Go online and look, and you can see if you can find someone there in Canada. Actually, I do know that because I know a few Canadian sexual medicine providers. So, yes, they are there. So, good. Thanks for clarifying so much. So, let's move to the next question. And
Okay.
this is from a Perry community member who says, I am so embarrassed to bring this up with my doctor. I feel too young for this conversation and silly to talk about it. What do I say to my provider? Dr. Johnson, what should this person who's embarrassed say to their provider?
Thank you so much for that question and your honesty. This is such a, a, a common thing that comes from women. And the truth is, 40 is not too young for these changes to begin. Actually, perimenopause can start in your late 30s and early 40s. And you might see some other changes that are happening. You might see some changes with your sleep, or your menstrual cycle may become more irregular. Your moods can change, but you're not silly, you're not broken, and you're not alone. Let me tell you that. This is so very common. But with things, if you're not sure what to say to your doctor, you can say things. You can actually say, I feel a little awkward asking you this question, but sex is feeling different for me, and sometimes I'm uncomfortable. Is this something normal, or is this something we can talk about? So don't feel afraid to talk to your provider. And if you find that your provider just dismisses you or isn't hearing you, it's okay to find someone else. It's okay to go to someone who will hear you and listen to you. And sometimes I think that it's not even that your provider doesn't hear you, is unfortunately in the United States and in training, doctors, especially in OB-GYN, even in my field where we deal with women's health and sexual health, we are not trained. And only about 7% of residents that come out of training feel comfortable talking to women and treating them for these symptoms. So it's not that they don't hear you sometimes, it's just they don't know. But you should still go and find someone else.
And I can say from a patient perspective, because I'm a sex therapist, right? I'm not uncomfortable bringing up um, sex to my physicians, but I have other things of my life I've been embarrassed about. And what I often remind myself of, this is a physician. They know the body. They have been trained on the body. That they've heard it all. And I really like what Dr. Johnson said. And I often tell people there's even a name for it. It's communicating about communication. It's like an entry into the communication. Sometimes just saying, hey, I'm embarrassed to bring this up, but here goes, really helps. And so, it's just really important. It's your body, it's your doctor. And if they blow you off, as Dr. Johnson said, if they say, I don't know, or if they tell you it's normal, you should just deal with the pain.
Or go home and drink some wine.
Yes, that a lot of doctors still say that. That is a signal it's time to get a new doctor. And again, go to get an ISWITch doctor or one from the Menopause Society who's got training in this.
Absolutely.
Yes.
Absolutely.
So,
Oh, I have a question, Laurie.
yes.
This is from another member of the Perry community. And the question is, lately, sex has started to feel painful and emotionally disconnected, almost like my body is working against me. Is this something that can improve, or is this just what happens with age?
Oh, I'm so glad you asked this. First of all, it is something that starts to happen with age in terms of the painful part, which is what Dr. Johnson has been saying, right? Our estrogen decreases, our vaginal tissue changes, and then sex starts to be painful. But the big message of this talk is you don't have to deal with painful sex. There are solutions. So the first thing is, yes, this happens with age, the pain part, but you can fix it. So what about the disconnected part? Well, first of all, that may have started with the pain. Because if something hurts, you're not going to go, oh, I want to go do that some more. You're going to pull back. You're going to pull away from whatever hurts you. And that includes your partner. So the first thing, see a physician, get these remedies to help deal with the pain. And then in terms of the disconnected part, a lot of this comes from some false beliefs that we have about sex. So, for example, when we were young, right, we were horny, or at least I was, most women, and we spontaneously wanted to have a sexual encounter. And then we stop feeling that way and we say, what's wrong with me? What's wrong with my relationship? And the answer is absolutely nothing. What we had in our youth is called spontaneous desire, but there's another type of desire called responsive desire, which is I'm responsive to the idea we're going to have sex, but I don't start out horny. Instead, I use the touch to get me there. And so, what I often suggest to people, again, once you have the pain taken care of, is having what I call trysts or scheduled sex dates. This is a scientifically supported technique. You set aside time and you say, this is our time for connection and intimacy. And you don't just like hop into bed and take your clothes off. You do whatever you need to do to get connected first. Maybe it's talking, maybe it's cuddling, maybe it's a massage, maybe it's one of those question and answer card decks where you ask each other things. You get connected. And then you have the sexual encounter. And you don't need to be horny to start it, but that will come as it gets going. And the other thing is, remember, we are older and things change. Like I can use my personal experience. I have a scheduled time with my partner, my husband, every week. And it's pain free thanks to Dr. Johnson and everything she's prescribed to me. But I then put out my lubricant on my counter next to my bed. I take out my vibrator, another scientifically supported technique that can also help with not only orgasm, but there's some studies with pain. And my husband doesn't have this issue, but many men also have erectile dysfunction, so they have to take a pill. So we have to get away from this idea that the only connected sex is that which happens spontaneously. And instead, we have to carve out times. And by doing so, we're saying this is important to us, and I'm being intentional around it. Think about you coming here today. You didn't spontaneously end up on your computer listening to us. You said, this is important to me. I'm going to take an hour for it. And you have to do the same thing with intimacy and really be intentional and carve out the time for it. And in fact, there was a study by a woman named Peggy Kleinpetz, and she wrote a book on it called Magnificent Sex. And she found out that when people do these things, their best sex starts happening. They have the people who had the best sex, they were 50 and older. Why? Because they gave up all these myths. Sex has to be spontaneous. Sex is penetration. So you can cultivate intimacy after you get rid of the pain. Would you add anything to that, Dr. Johnson?
Yes, I think in terms of, the physiology of preparing for sex, we have sex with our brain. That's one of our most important organs when it comes to sex. And when we start to think about these things, we start to release these neurotransmitters in our brain called dopamine and norepinephrine. Those are the feel good kind of things that get us excited. And just so you know that there are women who have issues with desire. Maybe they don't have pain, but they have issues with desire, or they have pain. The pain is now better, and they still feel like, I don't have any desire. I don't have pain anymore, but how am I going to get that desire back? There are actually FDA approved medications now for women to improve their desire. One of them is a pill. It's called flibanserin, and it's a pill that you take every night. The other one is an injectable medication called, the generic name is bremelanotide, and that is another kind of neurotransmitter that works in the brain, and it actually is something you use on demand. So you inject yourself 45 minutes before you want to have sex, and this really improves your desire. These medications work, they're scientifically proven, and you can talk to your doctors about it. Now, a lot of providers do not know about this medication or not aware of it. And so finding an ISWISH provider anyone in the ISWISH society should be able to help you with this medication.
Thank you so much for reminding us of that there are like people grieve that horny feeling. And so if you crave that and grieve that, there are medicines. When you said that those are scientifically supported, it also reminds me the other thing that's scientifically supported is erotica. And it doesn't have to be porn, like violent stuff. Ooh, most of us find that repulsive, but you can read an erotic book. They have audio erotica. And though women are aroused by both visual and audio scenes. So one thing you can do is listen to that, read that. If you find something that you find tasteful, watch that, but to get yourself in the mood. And some couples even do that together. So there's so much that you can do to kind of bring back that connection, that arousal. So those were all of the questions that we had from community members, but there were some questions that came in from providers, and we're going to answer those questions now. And I'm going to ask the first one to Dr. Johnson, and this is from a family medicine physician. And this family medicine physician says, when a patient comes in describing pain during sex, what physiological changes during perimenopause should we be thinking about first? And how do we figure out what's actually causing the pain?
Well, thank you so much for that question. I have been very lucky in my career to have worked with family medicine residents, and it's been thrilling for me to actually share some of my knowledge and experience with them. So this is a great question because I'm really impressed and glad that there are other non-gynecologic doctors out there or providers that are interested in helping women with their sexual journey. So I think we kind of went over this initially, but the physiologic changes are the most common thing you should think about when a woman comes in describing this pain is that it's probably hormonally related. It's probably because there are fluctuations in the hormones that support the vagina. And then again, that is the genital urinary syndrome of menopause. So what happens is, as the estrogens decline, the tissue of the vagina actually suffers. And so we need to make that tissue become vibrant again and bring back moisture and help with the elasticity of the vagina so that they can have comfortable encounters with their partner. Also, the testosterone levels are declining, and the tissue of the vulva tissue has so many testosterone receptors. And so in some cases, women can benefit from testosterone therapy as well. Generally, we reserve that for postmenopausal women, but in certain situations, a perimenopausal woman can also benefit from testosterone therapy. But this is what I would suggest. And the first, as you're trained in medicine, the most important and the key to like evaluating a patient is taking a really good history. Ask them the questions. When did the pain start? Where do you experience the pain? Is it with penetration? Is it deep pain? Do you have pain when you urinate? So all those kind of questions about their history. And then you want to do a really good, thorough pelvic exam. You want to look for signs of genital urinary syndrome of menopause. Is there changes to the vulvar tissue? Is there pallor? Is the vagina dry? Are the labia dry? Because they can be very dry. Do the walls of the vagina, they look different? Is there any discharge? And then, if you feel like this is the genital urinary syndrome of menopause, treat them. But if this doesn't seem to make a difference or it isn't the complete picture, because it may not be, then always think about referring to someone like me, an OB-GYN, who can do a thorough exam and possibly do some pelvic imaging, because there can be things like endometriosis, fibroids, other things that can be causing the pain.
Very good. Thank you so much. Now, when you say, I'm going to ask you a follow-up question.
Sure.
When you say to this family medicine physician, if you say, so you look at the, and I'm not a doctor, so I'm just paraphrasing, you look and it's like, gee, it looks like the genitourinary syndrome of menopause. So treat them. What would be the treatment for the genitourinary syndrome of menopause?
Well, generally, the first line of treatment is moisturizing. The recommendation is to use like non-hormonal treatment to see if that works. So things like the hyaluronic acid, and using that on a regular basis, 2 to 3 times a week, and see how that goes. Because a lot of women, there are some women who don't want to take hormones. Breast cancer survivors are very leery about doing it, even though it's safe. But they also have tried moisturizers, and it's actually life changing for them. If that doesn't seem to work, then you can use vaginal hormones, vaginal estrogen. You can use it in a cream, a pill, a ring, a suppository, and this is something that is just used 2 to 3 times a week. So there's not all this, daily thing. You have to remember it, but that can be very helpful. And then the other things that are, non-hormonal that can be helpful too. I send a lot of my GSM patients that have these menopausal, perimenopausal changes to pelvic floor physical therapy. There have been studies that have shown that it not only helps with the pain, it also helps the bladder, the urethra. Those organs definitely suffer because of GSM, and women are more prone to urinary tract infections. So pelvic floor physical therapy is certainly very beneficial. And then also, somebody like Laurie, Dr. Mintz can help. So, because a lot of sometimes our pain is not just physical; it's also psychological. I think maybe something that you can comment on, Laurie, in terms of how you would deal with a patient like that was getting better, but still having issues with pain or discomfort.
Yeah, and I think this is probably a good time to say, and tell me if you disagree with this, that when someone's in perimenopause, the most likely culprit, right, for the pain is the genitourinary syndrome of menopause. But there's other things, that need to be ruled out but also sometimes what happens is when someone starts having pain, they they get afraid and it lasts longer than the pain, if you will. Like
Mhm.
if your body starts to tense up in anticipation of the pain. So say you've been having painful penetration for a while, and then you get it treated, but you can't even get to the point of knowing, does this hurt or not, because your body does what bodies do. It anticipates something's going to hurt, so it tenses up, and it even tenses up the vaginal muscle, and so then it hurts from the tensing rather than the
The
original
dryness,
cause.
yes.
And so
Mhm.
for that, what would I would send someone to pelvic floor physical therapy, but I would also have someone do relaxation exercises by themselves. I would teach them how to relax their body, how to maybe use their finger or a dilator to insert something alone, starting small, while they couple that with relaxation so that we get rid of the association of penetration and pain. So again, so say someone gets their pain taken care of after, three, like they say, oh my gosh, this hurts. They go to the doctor, it's done. That's very different than someone who, and I've seen women like this, right, who have pain with penetration for months and months and months, but before they tell their doctor, before they tell their partner, and by then your body is guarding against the pain, and so more psychological relaxation may be needed, and also some discussion around relationship issues. When do you tell your partner that it hurts? I say always. When do you ask them to stop? Like really embracing and knowing this is your right to stop any activity that hurts, even if your partner is into it. So there's some psychological issues that come up around that. Thank you for reminding me of that and bringing that up.
No, I think sometimes we forget that it's not just a medical problem, it's a biopsychosocial issue, and we all need to work together. Sometimes it takes a village. And that's the beauty of this is that we have other avenues to go down and not just think that it's a medical problem, that it can be treated with a pill or a cream, because there are other things that could be in play in this situation.
Yeah. And, when we talk about like the biopsychosocial model, and we also talk about using three types of providers often: a sexual medicine physician, a sex therapist, and a pelvic floor physical therapist. Together, the three of us can really put our skill set together to help you enjoy sex, not have sex be painful. And I'm going to take a step back and say we're talking about pain in perimenopause, but there's a different kind of pain that some women have due to trauma. Often it's called vaginismus. It can be due to a sexual assault. It can be due to a bad medical exam that was painful. It can be due to so many things. And that's when the vagina, it's a muscle. And muscles do, if I was about to hit you, you would do this, you'd back up, you'd tense up. And our vaginas are muscles too. And so sometimes if something traumatic has happened to us, when we tense up and our muscles clamp and nothing can get through, but as we try to push it through, it hurts. And that's, for that, yes, there's some big medicines that can be used, like, but mostly that is a treatment that's done in conjunction with a
Yes.
sex therapist and a pelvic floor physical therapist, teaching you to relax your muscles. So if you're out there listening and you're like, oh my goodness, that's me, I'm not even in perimenopause, I've had that my whole life, that's a different type of pain.
But your pain is real,
Yeah.
and and again, you're not broken, and there are remedies and there are treatments that can be very helpful. And don't be afraid to ask about it. Don't be afraid to talk about it. And it's I see so many patients with this. I mean, they can't even tolerate a speculum exam. And they feel so afraid, and then they don't go to their provider. They don't get seen. So please, there's someone out there that can help you, and don't suffer in silence.
Yeah. And I've had so many women come to me who've had a provider tell them that's part of it, or their mother, this is what we endure as women. Pain is normal. Have a glass of wine, relax. If anyone tells you that, run, go the other way. Say, you are not
See
the
you
doctor
later.
for me, and you find someone that can help you, because there are people out there like me and Dr. Johnson who are going to say, your pain is real. Let's figure out how to get rid of it for you. Nobody should be dealing with pain. We should be eliminating pain in this area. This is a question from an OB-GYN who says, a lot of my patients are hesitant to talk about sexual pain. What can we do in the exam room to help them feel safe enough to bring it up?
Wow. So, yeah, it's not something that even though we're OBGYNs and we deal with vaginas all day long, we talk about vaginas, we talk about breasts. Many of us are not comfortable asking about sex, and it's unfortunate, but it's something that and the patients are afraid to ask about it too. They feel like they're ashamed if there's a problem. But the way you should do this is just normalize the conversation. What I say to my patients is, when I'm just seeing them for a well woman visit, and I'll say, a lot of my patients at this time of their life are starting to experience some intimacy issues. They might be having pain with sex. Is this something that you've been experiencing lately? Is this something that we could talk about? So once you that conversation up, I think you can even see it in your patients. They like, "Oh, I wanted to talk about that, and thankfully somebody's willing to talk to me about that." And then you want to use, open-ended questions. You don't want to ask yes or no questions, because you want to start the conversation. If you ask the question, say, are you having something like this? Is this something you feel? Have you noticed a change in your desire? That starts the conversation. So you want to ask open-ended questions. And you also want to watch your body language. If you're, we're so used to using EMR now. We're sitting at our computer, typing away, patients are talking, we're stop your typing. Take a minute, look at the patient, unfold your arms, don't jiggle your keys in your pocket, and listen to them. And sometimes it's okay to just stop talking. And there's always going to be that pause, that pregnant pause, and let them kind of regroup and think. Honestly, I know we're all rushed for time. I have 15 minutes to see this patient. But if you just give them that few minutes, you'll be so amazed. I mean, patients tell me, you know what? No doctor has ever asked me this. No one has ever explained this to me. And it doesn't take a lot of time. It honestly doesn't. We're talking minutes. And what you can do is you could change a life. The other thing I think is, you want to also invite them in. So some continuity of care. So maybe they're not ready to talk about it. Maybe you don't have time to talk about it, but this is an issue. What I do is I tell my patients, come back. This topic and this situation deserves your time, and I want to explain this to you so you can get my full attention. Bring them back for a follow-up visit. Patients are so grateful that you do that. You don't have time all the time to do that, so it's so important to do that. And validate their concerns. As soon as you validate, hey, what you're feeling, all my patients feel at this time of their lives. You're so normal, and we can help you with this. So those are the things that I would suggest, just to open the door for them, because no one usually does.
I love that. And I have doesn't everybody just want a doctor like Dr. Johnson? And, just asking the question, I think, is what she's saying. And, I've gone to a doctor and it's on their intake form. And that says to me, oh, they're comfortable with this. They know this is important. So I think it's just, showing your own comfort with the topic. And, I love what Dr. Johnson said about normalizing it. As a therapist, what I often say is something like, the vast majority of women, or more than 50% of women, have issues with desire. Is that an issue for you? So like letting them know they're not alone is so good. Um, and then we're getting back to solutions. Here's a question from a pelvic floor physical therapist saying, some of my clients can't or don't want to use estrogen. What are other effective low risk options we can offer to help ease the discomfort? So again, a pelvic floor physical therapist with patients and clients who don't want to use estrogen.
Mm-hmm. So I think we kind of covered this briefly, that there are non-hormonal low risk strategies that can be used for painful sex and discomfort that women are experiencing during the genital urinary syndrome of menopause time. And those again are the vaginal moisturizers. So hyaluronic acid. Some women like to use other kind of products that can help moisturize. There are products on the market, though, that you have to be really careful about. Things that can contain parabens and glycerin. These are actually, I would consider them more toxic than anything. They draw the water out of the vaginal cells. They pull on the water, so they actually make you drier and irritating. And they can cause redness, and you can easily get microabrasions and micro tears, even if you're using a vibrator. So vaginal moisturizing is so important, and you do that 2 to 3 times a week. I know Laurie and I both use a vaginal moisturizer, and it is just so you could just feel it just feels good, right, Laurie?
Yeah.
You can tell the difference. It's like moisturizing your skin. You get out of the shower, you put on moisturizer, and your skin feels so good. Same with the vagina; it needs moisture. Lubricants, again, with sexual relations. There are lubricants on the market there's there's something called low osmolality, where that is what holds the water in the vagina. There's actually some products on the market that are that recognize the World Health Organization guidelines in terms of what you can put in your vagina. And low osmolality type of products are on the market. You can look them up online. And you want to use those lubricants. You want to use them a lot, especially water-based lubricants. You need to apply them frequently. And don't just put it, if you're having sex with a male, you want to put it on the penis, you want to put it on your vulva, you want to be very liberal with the lubricant, and apply it more often if it's water-based. Silicone-based lubricants, you don't have to apply as often, but those are also very good. Some women like to use things like oils. Okay, so let's talk about oils. Coconut oil, pure coconut oil, and is really, really, really good. I mean, you can use that. It has been shown to improve, decrease the risk of infections. But sometimes women can get yeast infections. The more you use it, you can be prone to yeast infections. So if you're somebody that has problems with yeast infections, I would avoid oils. Olive oil, no, I don't like olive oil. It can increase your risk of infections. It's kind of stays around, and it's not really a healthy thing to use. So I would say if you're going to use an oil, use a coconut oil and a pure coconut oil. So again, you're a pelvic floor physical therapist, so pelvic floor physical therapy can be very beneficial as a non-hormonal method in terms of proving, decreasing pain. And certainly somebody like Laurie, sex therapy is also very beneficial. Some therapy out there is non-hormonal, and it's laser therapy for the vagina. Honestly, it has been helpful for some women, and it's not approved by the FDA, but there are gynecologists, urogynecologists that are performing this procedure, and it's kind of an out of pocket, not covered by insurance, but that's in some populations it can be very beneficial as well.
So I'm going to ask you a follow-up question, and then I see some questions I'm going to address in the chat before we go to our final question that came in before this. But you talked, Dr. Johnson, about all these things: moisturizers, lubricants, that kind of thing. But one thing I would like you to address is maybe this pelvic floor physical therapist could also help that woman not be afraid of vaginal estrogen as well. So can you talk about why should we not be afraid of vaginal estrogen?
And it's such a shame that this whole study that came out from the Women's Health Initiative, and just putting all estrogens into one big pile, right? Systemic estrogen, which you take orally or wear as a patch to give you, to help with your hot flashes and other symptoms that happen with perimenopause and menopause. But vaginal estrogen is a topical product. It is life-saving. And there is so much evidence that there is very little absorption of estrogen into the bloodstream. They've actually done studies where they've taken blood from women before and after, and there was no increase in estrogen. And the issue is that the FDA says that all estrogens can cause cancer, blood clots, strokes, and heart attacks. The real deal is this is not what happens. And what happens as women get older is they're more prone to urinary tract infections. Those urinary tract infections can sometimes be asymptomatic, and it could then go to your kidneys. You could get a kidney infection, and you could get sepsis, and your whole body could shut down and you could die. And so the Menopause Society has come out and said that this should be a lifelong treatment for women. It does not cause cancer, does not cause strokes, heart attacks, or blood clots. In a small number of women, small amount of women, you shouldn't, there's some populations that shouldn't be using estrogen. And those are women that are just recently diagnosed with a blood clot. They have a newly identified cancer in their breast or some other kind of cancer that likes estrogen. So that's a very small population of women. Everybody else should use vaginal estrogen the rest of their lives. My mother is 88 years old, God bless her, and I have her on vaginal estrogen because she has bladder issues, and this is possibly saving her life down the road and prolonging her life. So don't be afraid. And there's actually now a movement. We're trying to get that warning removed from the box. And that actually happened yesterday. And some of our important, colleagues in sexual medicine and have went to the FDA to talk about removing this warning from the box, the black box warning.
That is exact. We are on the same page because I was actually going to say that there was a hearing yesterday. So what this pelvic floor physical therapist can do is help her patients not be afraid of vaginal estrogen. I'm going to self-disclose. I use a vaginal moisturizer twice a week. I use vaginal estrogen twice a week. I'm also on systemic hormone therapy. I take estrogen systemically. I take progesterone because I still have a uterus and you have to take both. And I use testosterone. And, it has changed my life. And I have some medical issues and I still can take these things. So, I will always take these things. So please, those myths I went to a talk when I went to Ipswich with Dr. Johnson, and someone was talking about this study that scared women. And if I'm remembering correctly, there are only 22 women in this study. And the actual results weren't significant. They got way blown out of proportion. So don't not only be afraid of vaginal estrogen, but don't be afraid of systemic hormone therapy. Talk to someone like Dr. Johnson who knows their stuff and who can tell you the actual risks and what the studies say. So we have one more question that was for me, but I'm going to go to the real quick before we do that. There's 3 questions in the chat. Where do we both practice? Where's our clinic and location? I'm in Gainesville, Florida. I am not taking new patients, but you can find me online and I can help refer you to people who are taking new patients. And Dr. Johnson?
I am right now currently going to a new location in Pennsylvania, but I've worked in Florida and I'm licensed in Florida and New Jersey, but I'm going to be practicing in Pennsylvania.
And then someone also said, don't use coconut oil if you're using condoms, correct? Yes.
Correct.
Yes.
Correct. Good question and comment. Thank you so much.
Yeah. And that also reminds me, I also use lubricant when I have penetrative sex, like Dr. Johnson said. And water-based lube, again, like she said, it has to be applied a lot. Silicone lube stays moist. They often say don't use silicone lube with silicone sex toys, but I've recently read that's because people don't want to take responsibility for the fact you might need a new sex toy. I always use silicone lube with my silicone sex toys.
Me too.
And nothing's ever happened bad, but you can use a little spot test. And I think we have just one more question
Yes, I have a question. So Laurie, this one is from a clinical psychologist. The question is, I often see women grieving the loss of pleasure. How can we help them reconnect with intimacy? Not just manage the pain, but feel empowered again.
What an important question. I think I see this a lot. And I think, again, the pain, let's assume that this person has seen someone like Dr. Johnson and the pain is gone. But what they're grieving is their youth. They're grieving when they were horny. They're grieving that. And of course, we grieve that because it was a marvelous feeling, right? And what I think I would want you to do is to educate them that relationships go through stages, and The first stage is called limerence, and it's actually a biological event. It's almost like an obsession. We can't get that person out of our mind, and we're obsessed, and we keep wanting to touch. That is a biological stage that lasts 6 months to 2 years, and then it's gone. Nothing's wrong. Your relationship's maturing. And you go through stages. And the later stage is so beautiful. It's called companionate love. You are best friends. You are partners. You're no longer horny in each other's presence. Of course, because you couldn't like live life if you were always horny like that. Raise kids, have a job, deal with grandchildren, illness, whatever. You are life partners. You are companions. And no, you're not horny anymore in each other's presence, but you can still have amazing, beautiful sex, better than before, because it's based on that companionship. But it's something that needs to be cultivated with conversation, with experimentation, with connecting, with trying new things. It's never too late to try new things. And we know that couples who do new things feel more connected. So telling them, you can grieve your youth, but you still need to adjust to where you are. And the best example I have of this that I often tell people, I had a client, and this was a male client, and I adored this client. So that's why we had a good relationship. I could use humor with him. He was bald, he had a hearing aid, and he had been a pretty big football star in his day. And he was sitting in my office one day, and he said, my erections just aren't what they used to be. And I said, does it bother you you're bald? And he was like, what is wrong with her? But he answered the question. And he was like, no. And I was like, what about your hearing aid? Does that bother you? And he started to get it. And he said, no, it helps me hear. And I said, oh, time's up. You're the quarterback of a major team. You're late. Time to go. And then we got into a discussion about how he had accepted and adjusted to his other aging things. He had got a hearing aid. He'd actually also had cataract surgery. We talked about that. And that he adjusted to those things. And the same is true with adjusting to your age as you and your sexual connection. It can be just as good, better than ever, if you start treating it like with the grace of change, instead of expecting yourself to still metaphorically hear and see like and have the same hair as when you're 18. So it's really it's a lot of education. And again, telling people they can have sex that's better than ever because they're doing it with communication, intentionality, and connection, and the wisdom that comes with age. So that's what I often do.
Please share this with your friends and tell them about this, because I have a story, and I know I have a couple seconds, but every year I go away with my high school girlfriends, and there's 12 of us. And we were all one day out in the pool swimming, and they started asking me questions about sex, pain and sex. And not one of those women had ever been offered vaginal estrogen. They had no idea that it even existed. And these are women that were way past menopause and were so sorry, and they were just angry that no one had ever talked about. So please share this with your community, with your friends. Tell them there is help out there. Don't let anyone live in silence anymore.
Oh, I love that. That is a beautiful way to end. And thank you for the kind comments. I'm so glad you liked the presentation. Someone says they're reading my book and loving it. Thank you so much for being here. And we don't want any of you to have painful sex. And every single one of you listening can have pain-free sex, lubrication, intimacy. It's out there with the biological and the psychological and pelvic floor help. So
Yes.
thank you.
Yay.
Yay. And we don't hang
Have good sex. Have good sex.
Here's to good sex.
Yay.
Okay.